Good afternoon. As has been introduced, my name is Wairimu Karaihira, a clinical pharmacist, and topic was management and health-related quality of life amongst prostate cancer patients at Kenyatta National Hospital. Next slide. So, according to global cancer statistics, and the fourth most common cancer worldwide, we manage prostate cancer either by watchful waiting or observation, surgical, so radical prostatectomy, radiologically, using radiotherapy, whether external or brachytherapy, and pharmacological measures. The modalities used depend on disease stage of the patient, their risk stratification, and the life expectancy. So, past studies have shown that the treatments used have a significant impact on the quality of life of these patients, and failure to investigate this quality of life increases the chances of long-term deficits for these patients. So our main objective was to evaluate the management of prostate cancer in Kenyatta National Hospital, as well as to see their quality of life. Health-related quality of life basically looks at the total well-being of a patient on management for prostate cancer. So the study was a descriptive cross-sectional study carried out at the Cancer Treatment Center, as well as the urology clinic of KNH. The study population we were looking at were adult men who had been on management for prostate cancer for at least 4 weeks of therapy. We looked at 62 participants. Data was collected using a structured questionnaire, as well as already established questionnaires by the European Organization of Research and Treatment of Cancer. These are questionnaires that had previously been validated in our country, but had not been used for prostate cancer. We also got ethical approval from the KNH UN Ethics Review Committee, as well as the hospital. So our results, we found that majority of the men in this study were in the age group of 65 to 74 years, which tallies with global statistics. Many were pre-obese, they were married, they had retired, were of low socioeconomic status, and a majority of them were on NHIF. As far as their clinical characteristics were considered, many of them had late-stage disease, so metastatic prostate cancer, and were diagnosed with more advanced disease, so highly differentiated, as well as a high PSA. And 67% of our patients had at least one comorbidity, hypertension being the most prevalent. The issue with this is that we could not establish whether the comorbidities were as a result of drug therapy or they came afterwards. Majority of our patients, 80.7%, were on hormonal therapy, which makes sense because many of them had metastatic disease. So hormonal therapy was either androgen deprivation therapy using goserelin. We had one patient who had undergone orchiectomy, that is removal of the testis. Or the patients were on combined androgen blockade. So ADT plus either bicalutamide, commonly known as Casodex, or abiraterone, prednisolone. Yes. So the most common drug used was goserelin in combination with bicalutamide and zoledronic acid. So prostate cancer on metastasis, it prefers bone, and these patients are at very high risk for pain, as well as pathological fractures, cord compression as well. So many of them had been put on bisphosphonate therapy with zoledronic acid. We also looked at what symptoms and signs the patients had experienced post-diagnosis. So majorly they had sexual dysfunction, urinary dysfunction, as well as hormonal side effects. Again, it was, one of the limitations was establishing temporality of these things. So did they start, were they because of the cancer itself or because of the hormonal therapy? As for quality of life scores, the overall quality of life of this study population was 65%, which we would say is moderate. It's not too bad, but equally it's not very good. Amongst the functional scales, we saw that emotional functioning scored the highest, while sexual functioning scored the worst. So the way this tool works, the functional scales, the higher the score, the better the patient is doing. But for the symptom scales, the higher the score, the worse the patient is doing. So as for the symptom scales, financial difficulties or financial toxicity was a major complaint for this patient, despite the fact that many of them were on NHIF. So then we also looked at predictors of health-related quality of life in these patients. We wanted to find out really what worsens the quality of life in such a patient. And we found that fatigue near the bottom affected majority of the scales. So it had an effect on physical functioning, role functioning, emotional functioning, physical, role, social functioning, financial difficulties, as well as the global health or quality of life in general. So in conclusion, we saw that majority of these patients were on hormonal therapy, either purely goserelin or goserelin in combination with other drugs. And fatigue was the most important. Education be done to ensure that this disease is caught early, meaning the patient is just subjected to localized therapy, and they don't suffer the adverse effects of hormonal therapy. Secondly, in some instances, some patients were not being managed the way that they are supposed to be. So even if a patient develops metastatic castrate-resistant prostate cancer, they still should be on androgen deprivation therapy. in some instances, that was not the case. We also recommended that assessment of health-related quality of life should be included in the day-to-day care of all these patients so that we can catch some of these things early and ensure that we take care of them, particularly the financial difficulties. So NHIF covers so many sessions. What happens after that? And what happens to the things that NHIF does not cover? And then finally, we recommended that a prospective cohort study be done because quality of life is dynamic, and we also need to determine the temporality of some of these things. And also a study to assess the degree of adherence to national and international guidelines. Thank you very much.